So I'm here the day after the Easter bank holiday with
Ian Smith,
who is part of
Canute Medical Solutions Limited.
Right, and we've been talking a bit about retinal screening and the fact that we used to use the local optometrists, and then somebody decided that was probably too expensive, so they set up a sort of in-house NHS service. They come around to GP surgeries, and considering that it's got something to do with the NHS, that seems to work quite well, be quite efficient, so people are happy with that. But you've got a sort of new super service which is based on having trucks come around.
Sure, we've always looked at a scalable service. So
yeah.
It's built modular, so
yeah.
if you've got an existing service, it can be used as a catch-up, a support, a sickness cover. So
yeah.
we supply the software to run the entire service.
Right.
There's no large fee to set up. It's paid per patient episode. So as you use it, you pay for it. It's got all the management infrastructure there, so GPs can manage it, refer, and give. So
the GPs are in control.
Are in complete control, and they can refer to themselves, to the NHS trust, or to an alternative provider of medical services, i.e. the independent sector. The whole idea is that we supply the complete service. So, for example, with the software, you can do the screening.
Right.
If you haven't got a screener there, a trained screener, they're meant to be there for whatever reason, you can just use somebody who can use a camera and take the photograph.
Really? It's that simple?
It's that simple. So once a photograph is taken, it can be sent off immediately to our diagnostic centre, which is online. The patient information is synonymised at source with the GP.
Right.
So all that we get is an ID number and the photographs. It's then graded by ophthalmologists.
Okay.
QA is all done, and then it reports back. Once that's done, and
presumably if it's a GP doing it, they don't hesitate to say this is too crappy a picture for us to
yeah, I mean,
make
the
a judgment
ophthalmologist, all the screener is trained to do at the moment, or a photographic assistant as we could call them, so you can use unskilled labour or staff that you have here, is that they take the photograph and they're trained, is that a good image, can you make a diagnosis from it or not? Right. That's all they've got to do. So that's why they're quite easy to replace for sickness, staff migration, holiday cover, anything can always be covered. Because it's, the image, the important part of it is being diagnosed by a doctor who's been through medical university. There's lots of people saying that the screeners now, with the City and Guilds course, are going to be allowed to do the grading. As an ex-medical technician myself, I'd be quite worried because I don't have the same medical malpractice indemnity as a doctor. You can't get that insurance. What happens if I actually make a misdiagnosis and that patient goes blind? There's a whole host of things that you should
So you're from a bit of a medical background, aren't you?
Yeah, my wife's a consultant anaesthetist. My mother-in-law's a GP. I'm actually a medical technician at Woods Cross in the Hamilton Hospital.
Yes, so what chance have you got with that sort of associates?
Yeah, so the whole point is the scalability. So you've got that service there. The other thing that we've said as well is we're also doing, you'll find an incidence rate when they're being screened. Patients not being able, the screener not being able to look at the macula or the retina because some of them have cataracts. They're then going to be referred for biomicroscopy.
Right.
Waiting list, more money, as I said, outpatient waiting list, blah blah blah. But we can do that as well. So the patient is there. Oh, we can't do it. Let's do the biomicroscopy right there. No waiting list, no extra money. It comes in with the price.
So the price being a sort of standard price for the unit.
It's basically the service and the unit. So the more of our service that you use, the more cost effective the unit becomes. Because the unit, depending on how big they are, 40-foot, 3 rooms, secretary, 2 nurses, and all of the equipment for doing the screening and for the treatment can cost up to £10,000–15,000 a month. Depends how big they are.
That's if it stays in one place for a month. But presumably you can have it for a day a month.
You can have it for a day. You can have it for 2 days, whatever your contract for.
Right.
And that's the cost. But in that, so for example, we can screen 20 patients per day per room. 10 in the afternoon, 10 in the morning. Sorry. And so if you've got 2-3 rooms there, you've got 40 patients.
Yep.
Again, we know incidence rate, people are going to need biomicroscopy. We can check for that. But also while they're there, we know that the incident rate of glaucoma, people over 40 who've got diabetes, is raised as well. So shouldn't that be tackled right there as well?
Oh, right. So you can do that while they're there.
So why send them off again, have a waiting list? another referral to your local secondary care. It all just
more
ends up
expensive.
cost money.
Yes.
It's not a good patient pathway. It's not really good for the patient, we don't think.
No, and the GPs also want to be in charge of the cost,
yes.
and
so
which presumably they make all the decisions as they go.
All the decisions, the software sits with them, the service sits with them, we can do as little or as much as is needed. Then the software integrates with, it sits between the GP practice and Choose and Book. Choose and Book at the moment, you're meant to be able to choose from 4 different suppliers,
right.
and one of those is meant to be from the independent sector. It's not really happening at the moment. But with the software that we've got, you can populate it so a GP can refer to his local NHS hospital, to his own practice if he's got an interest in minor surgery, to the independent sector. So you can then sit with the patient and say, okay, then we can do our GP surgery with our mobile units next week. The hospital, we've got to be referred, it costs more money, and then they'll tell you when you can have the treatment, which could be anywhere from a month to 2 months after your thing. Or if the GP wants to do it, the GP can do it himself. But again, it is patient choice at referral, and it's proper patient choice at referral. So you've basically got a service which we think is gold standard. You can use as little or as much as possible. You're in full control of your budget, and the patient's got true patient choice where they go. What
about consent? Do you do that?
Consent, yes. We've got a full consent system, which was one of the first products we ever developed. It's being used by the NHS at the moment in numerous hospitals. When you're dealing with an alternative medical provider, you should always inform the patient that you're going to be sharing some of their basic information. So with the software that you've got, which sits in your GP practice, you can write to your patient, you program if you've got 2,000 diabetics, 1,000 diabetics, if you've got 100 diabetics, you're doing a GP by GP. So we've got an alternative provider who can do all of this for you. We send them the NHS consent document. We send a consent document asking them that we're allowed to share their information. We only use it while it's very fleetingly, because as I said, when it goes offline, when it goes to be diagnosed, it's anonymised, so we never see it. Once that record has been reported, it's got rid of.
Okay, so good on confidentiality.
Yeah. We also give them a patient information document, which I've also given you, explaining the procedure, what they're having done, and alternatives. So you get a whole patient information package as well.
Okay, and of course the big thing everyone's worried about is we've got loads of diabetic patients. They're coming out of the floorboards. We're seeing more and more all the time, but we know there's loads more even than that. So this will give us a little bit.
Yeah, we can do that as well. I mean, if you've got somebody that what you do find as well is you may have diabetics that are known but lost in the system. So they may not be in a diabetic clinic, they may be in a clinic for some other disease. But the reason why that is because they're diabetic. But we can, if you've got patients that you're worried about, we can actually screen them for diabetes. It's quite a simple test, as you know. We can do that as well. And it's a service that we would actually offer out to the general population when we're in an area. Are you overweight? Do you smoke? Do you do any exercise? Have you got this and this problem? If so, you should come to us.
Yes, so it's sort of cough friendly, because if you feed that back to the GPs, that's the sort of thing we have to keep records of.
Yeah, and the thing that I think that my mother-in-law as a GP really likes, and we sort of designed this around her needs, is that the GP's in full control of it. Full control of the budget. They know exactly what they're doing and spend it and do it. So rather than having outsourcing it to a static clinic, we're having to build onto something, and they're going to do 4,000 patients over a year, for example, taking a PCT. We can say, well, no, we'll actually put the entire infrastructure in there, and we'll do that for you in a month or 2 months. So you've hit your targets in the first 2 months, you've spent your money, you've got your rewards, patient's happy, you're happy, and we come back same time next year.
Okay, yeah, that sounds very good. If you send me some details by email, I'll pass that on to whoever's interested, and it sounds as if something may come of it. So thank you very much indeed for your time.